Few institutions can claim to have been there at the birth of modern medicine. And while Johns Hopkins' impact reverberates around the world, its genesis began with the stroke of a pen in 1873, when a gentle Quaker man put his vision into a letter that would inspire and heal generations to come.
In all your arrangements, you will bear constantly in mind that this is my wish and purpose, that the institution shall ultimately form a part of the medical school of the university.
A medical school that would redefine how medicine was taught and practiced, and would redefine who could study and practice.
And inasmuch as my interest is in the medical education of women, they shall enjoy all the advantages on the same terms as men. And the medical school shall form an integral part of the Johns Hopkins University, providing a 4-year course leading to the Doctor of Medicine.
Advances and breakthroughs continued to revolutionize medicine. Diseases previously pursued under a microscope are viewed today through a much broader lens, wide enough to examine the scope of patients' experiences, genetic predisposition, and access to care. Information and data so vast and revealing, the result is targeted therapies and cures that our founders could have only dreamed of. The vision embodied by the first class of 18 students paved the way for thousands more to follow. Pioneers all, physician scientists devoted to research, clinical care, and educating the next generation. And as our understanding has grown, so has our reach. Collaborations in nearly 100 countries. Today, our community is the world.
Good afternoon and welcome to the 2021 Johns Hopkins University School of Medicine Reunion and Alumni Weekend Symposium. I'm Diane Orlinsky, President of the Johns Hopkins Medical and Surgical Association. Our association is always honored to co-host this weekend of programming with Dean Paul Rothman. Our commitment to connecting alumni to the institution and enhancing the lives of students and trainees is stronger than ever. This symposium is a cornerstone to our Reunion and Alumni Weekend. It's a special time when we as alumni have the opportunity to connect with the institution through stories and updates from leadership, faculty members, and students. While this year continues to feel and be different in so many ways, including the virtual nature of this program, what remains the same is the significance of the School of Medicine in advancing research, providing cutting-edge and quality clinical care, and training our future scientists and physicians. And with that reassurance, our pride as alumni, whether we graduated with a degree or completed training here, continues to swell. It is a pride that will always resonate with us because of experiences that propel us in the work we do. Our program today will give you unique insight into what the School of Medicine has been like in the past year during the COVID-19 pandemic. You will hear stories of resilience and hope through what has been an incredibly challenging time. You will see the strength of this institution and the people who are a part of it. I would now like to introduce Dr. Paul Rothman, Dean of the Medical Faculty and Chief Executive Officer, who will provide an update on Johns Hopkins Medicine.
Thank you, Diane, and I want to thank all of you for joining us today. We have a very exciting program for you. You know, over the past 14 months, Johns Hopkins faculty and staff have been working incredibly hard to do everything we can to fight the pandemic. Our doctors, nurses, researchers, teachers, and technicians have done so much and have showed such incredible dedication, sacrifice, and resilience. Their spirit has been so essential for us to help battle the pandemic. Treating patients is just one part of the things we've been able to accomplish during the past 14 months. During the pandemic, we've continued to educate our medical students, our PhD students. We've been able to pursue our research on COVID and on non-COVID areas. We're also deeply involved in testing, distributing vaccines, and helping our communities, especially those who need us most. In addition, we're collaborating closely with our colleagues across the university, including those in the schools of nursing, engineering, and public health. A shining example of this is the famed COVID map, which is now part of the Johns Hopkins Coronavirus Resource Center, which is a university-wide initiative designed to share our institution's broad expertise with the world. The Resource Center has been recognized by Time magazine as one of the most important inventions of 2020, and earlier this year passed over 1 billion views, which is a staggering milestone. This effort exemplifies the indispensable societal role that research universities such as Johns Hopkins play, especially in times of crisis such as this pandemic. You know, our clinical faculty and staff have saved hundreds, if not thousands of lives, and have helped tens of thousands of people in Baltimore, in Maryland, in the District of Columbia, and around the country. Since the beginning of the pandemic, Johns Hopkins has treated more than 30,000 COVID-19 patients, many of them severely ill. We regularly see the most complex cases, and over the past year, our clinicians have learned an enormous amount about how to best treat patients with COVID-19. To give you one example, early in the pandemic, our clinicians began to place severely ill COVID patients on their stomachs, a practice called proning. This increases the amount of oxygen that flows to the lungs. We've also learned a great deal about the antivirals such as remdesivir and steroids such as dexamethasone. We've really been focusing on using our clinical space as efficiently as possible so that we can treat both all the COVID patients we need to and all those patients with non-COVID diseases. You know, over the past 14 months, Johns Hopkins Medicine has performed more than 600,000 COVID tests. Since the beginning of the pandemic, we've been sequencing some of the viruses that we recover. These days, we're sequencing about 300 to 400 viruses a week. We do that so we can pick up some of the variants that you hear about all the time. We've detected almost all the variants you read about, those from the UK, from South Africa, from Brazil, from California, from New York. And you know, over the past several weeks, we've noticed that the B.1.1.7, the UK variant, is now by far the predominant variant here in the Maryland-Baltimore area, with over 80% of our viruses being the B.1.1.7 variant. Since the beginning of the pandemic, we've partnered with the University of Maryland Medical System, the state of Maryland, and us at Johns Hopkins to think about how we can best care for people in the city of Baltimore. At the Baltimore Convention Center, we opened up a site for the care, treatment, and testing of those with COVID-19. At the Convention Center, when patients are ready to be discharged from hospitals but not quite ready to go home, the patients can spend days there under our care. Early on, we started to offer testing there for anyone who needed it in the city of Baltimore. And over the past several months, it's been a site where anyone could come and get COVID-19 vaccine. It's been a wonderful collaborative effort to help those who most need us here in the city of Baltimore. We're also working with vulnerable local communities to ensure that they receive the help they needed. One thing we've done since April of 2020 is provide meals for those who need it, and we've been able to provide more than 4 million meals to those who need us here in the city of Baltimore. We're offering free testing in East Baltimore, especially in the Latinx community who've been hit very hard by the pandemic. For those who test positive, we offer a range of services to help them and their families. This work is, we started it, but now we've received $1.5 million from the NIH to continue this work. You know, we've played a central role in vaccine distribution, not only for our own healthcare workers and for the university faculty and staff, but to our patients and also to the wider community. You know, this effort has distributed more than 220,000 vaccine doses. We're providing vaccine to those who need it. So, for example, the Baltimore City Public School System asked us, and we're helping them vaccinate the teachers so that they can get back to working with their students. Washington, D.C., we're vaccinating residents of low-income senior homes throughout the city. Over the past 14 months, we've taken the lead in COVID research. We have more than 500 ongoing IRB trials for COVID-related research studies. One example of this are 2 large trials using convalescent plasma to treat patients with COVID. These trials received over $35 million in federal funding. In addition, we're using our databases and our precision medicine platform to try to understand more about this disease. For example, try to predict who will get ill from the disease at time of admissions so we can triage them better. Also trying to use our big data platform to understand who will benefit from which types of therapies. In the US, the pandemic seems to be easing, but we don't think it's going to totally go away anytime soon. We recognize that we are blessed to have a fantastic group of faculty, students, and staff. We continue to work hard in the care of our patients to ensure that our learners, our students, residents, and fellows get the education they need, and to lead research to help us triumph over this virus. Thank you so much for joining us today, and I hope you enjoy the rest of the program. This has been an extraordinary and difficult year. One of the great things about Johns Hopkins is its collaborative atmosphere. Frontline nurses, respiratory therapists, environmental service people, security people, house staff, physicians. Subsequently, you have to think about just the sacrifice and bravery of everyone.
My name's James. I'm one of the senior general surgery residents at Hopkins, and I was redeployed to the COVID ICU over the last month.
One of the hardest things in the ICU, normally there are, pictures of people that are brought in by their family and, things from home that sort of allow you to understand who a person is and remind you, what it is that we're actually doing. We're taking care of a person with a disease, not treating a disease.
This is hard. So the fact that we're all at risk and we put ourselves out there, to the fact that we're isolated. I mean, we've de-densified. A lot of people are working from home. It's new, it's different. We're on Zoom all day. We're not seeing people. We're social creatures. We miss the interaction, and we're scared. And then we've had a turbulent election that was another big stressor on people. We've had social unrest. We've had the deaths of African Americans in police custody, and that's put a strain on a lot of people. We have a lot of resources from the Office of Wellbeing and others that if people need help, we want them to avail themselves of the resources that we've made available to them to get the help they need. So we think coming out of this, we're going to have great opportunities, and then we're going to just grow we think in an unprecedented way after the pandemic's over. We're thinking through strategic goals of expanding our physical footprint, thinking about how we care for patients in a larger geographic area. We think telemedicine is going to give us opportunities to expand our care in areas and to patients that we couldn't before.
It's going to take a while for us to recover from this, but the best thing is that we learn and we use those projects and those creative, innovative ideas and bring them forward to change healthcare.
And then finally think about what we could do globally to help people, either in terms of new therapeutics or new research or advocacy for the public health measures that we think are really important. If you think about the speed of both getting these therapeutics and these vaccines are at a pace unprecedented in history. This has been an all hands on deck effort and have done so just because it's what we do. We take care of sick people when they need us, and it's really deep. People have worked so hard. We are a family here together. We'll get through this together.
Dr. Rothman, thank you for providing an inside look into the current state of Johns Hopkins medicine. We will now hear more about the life of students and trainees and what medical education looks like in a virtual world during a pandemic. I would like to introduce Dr. Roy Ziegelstein, Vice Dean of Education for the School of Medicine.
Thanks, Diane. This has been a challenging year with the effects of the pandemic on the way we teach, learn, conduct research, take care of patients, and interact at the medical school and in our daily lives. On top of that, nearly every day we've witnessed acts of inhumanity, systemic racism, and hatred in the world. And while these issues no doubt affect every feeling member of society, the burden and the pain are not equally borne by all. And this has clearly affected the daily life experiences of our students, residents, clinical fellows, and postdoctoral research fellows this past year. And I think there's been something most unusual about this past year, at least with my experience with students and trainees. In most instances and at most times, faculty and staff have been able to reach into a deep reserve of emotional resources and support to help young people who face these significant life stressors. With the usual stresses that accompany professional growth and development, academic stresses, financial stresses, and the like, faculty and staff are generally not simultaneously experiencing challenges, and they have deep emotional pockets to reach into to help. Not so this past year, when these stresses have affected all of us. It's resulted in a different way of supporting our learners. I still recall how one of our residents described life in the early pandemic as a time when the usual academic hierarchy was suspended, at least temporarily, and when residents and faculty worked together, both deployed to care for very sick patients infected with COVID-19. And how sometimes residents even had to show or remind senior faculty how to manage ventilated patients in the ICU. There's also been a suspension of the emotional hierarchy, if you will, and the faculty and staff have had to take on a new way of supporting trainees, becoming comfortable recognizing and revealing their own vulnerabilities, even as they supported our students, residents, and fellows. As I provide you this update, it seems to me that in addition to an inoculation of COVID-19 vaccine, each of us needs another shot in the arm, an injection of optimism and hope for the future. I hope my comments here give you that injection of optimism and hope as you hear about the lives of our students and trainees, future leaders in medicine and science. Early in the pandemic, our medical students had to pause in-person instruction, including clinical rotations. While that was only for a few months, it had a significant effect on our school and on their academic progression that we had to adjust to quickly. Clerkships had to be shortened from 8 to 6 weeks and from 4 to 3 weeks. And our faculty had to think creatively to develop a variety of outstanding online electives in very short order. Once the new academic year began, anatomy and clinical skills were still taught in person here in a de-densified learning environment with our students and faculty wearing masks and face shields. Some other schools made the decision to do both of those things remotely. And so there are actually cohorts of first-year students around the country about to make the transition to second year who've not been taught clinical skills in person and who did not do cadaveric dissection, whereas our students have done both. As we all know, medical school is not just about acquiring knowledge and skills. The inability to gather socially has had a significant effect on our students, especially the first years, since they've not had a chance to get together as a group and get to know their classmates outside of the anatomy lab. Also, some of the areas where medical students learn on the wards had to be de-densified, something that continues to this day. So even when medical students returned, their learning has been challenged by the limits placed on the size of teams in workrooms and even at times in patient rooms. We've had to be creative in terms of devising ways to connect teams for conferences and patient discussions at a distance. Of course, one of the important things in a medical student's life are milestone events like white coat ceremony, match day, and convocation. Some of these had to be postponed or converted to online. A clever solution for this year's white coat ceremony, which will take place next month, was developed by Mitchell Goldstein and the college's advisory program. The program will take place in the Armstrong Medical Education Building, with students spread throughout the building in small groups approved by our infection control and prevention experts. They'll be watching the event on their computer screens. While some of the event will be pre-recorded, periodically, small groups of students will be called to come to the main lobby area for live coding by their college advisor, all captured on live video camera. Match day was virtual this year, and convocation will be predominantly virtual, with an outdoor gathering of graduates that morning to celebrate the event safely. Remember that our graduating class had all their internship interviews remotely this year, as were all interviews for medical school applicants around the country. This created new challenges and at the same time, new opportunities. On the one hand, students and medical school applicants didn't have to spend money to travel to places to interview, but on the other hand, applicants had to make choices about programs they couldn't even visit, and they had to think about how to present themselves online in a remote interview. Schools and residency programs had to be creative to find ways to show off the institution remotely. We prepared our medical students for Zoom remote interviews and tried to help them learn about residency programs in new and creative ways, since they couldn't visit them in person and couldn't do elective rotations or sub-internships there. Hopkins residency programs developed special remote electives and other remote experiences to show medical student applicants what residency training is like here at Hopkins. I still recall being an intern applicant many years ago, and I can easily take myself back to that day in December 1985, when I walked into Johns Hopkins for the first time and went on morning rounds with the team on Osler 4 before my interviews. I've told other groups that to me, that day was a lot like falling in love. I immediately felt the Hopkins presence and culture and everything that's distinct about this magnificent place. Creating a way for students to get that sense remotely was challenging. Nevertheless, our medical students did extremely well in the match this year, with about 25 to 30% remaining at Hopkins for residency, a similar percentage as in most other years. Residency programs also did well, and in fact, some program directors told me that they felt this was their best match ever, at least on paper. Of note, our residency programs made a concerted effort this year to attract medical students from underrepresented backgrounds, and that seems to have paid dividends. This year, 21% of new interns starting this July at Hopkins will be from groups that are underrepresented in medicine, compared to only 14% 2 years ago. This is truly an amazing accomplishment, especially when one considers that, as many of you know, and as recently reported in the New England Journal of Medicine, Black male medical students account for only 2.9% of the national medical student body today, a lower percentage than in the late 1970s. I want to turn to our residents and clinical fellows. They have been nothing short of amazing this year. There's no doubt that the pandemic affected training this year in significant ways. Some of you may have seen a recent study that showed that surgical residents across the country noted a significant decline in the number of cases performed during the pandemic, especially certain ambulatory surgical procedures were postponed or canceled during the early months of the pandemic. Although our residents at times had to be deployed to care for patients with COVID and perform functions quite different from what was expected for their specialty training, they nevertheless have been able to maintain their focus on their education and training and their academic progression. This is a testament not only to our residents, but to the amazing leadership of our residency and fellowship program directors and our Associate Dean for Graduate Medical Education, Jessica Beanstalk. The pandemic posed similar challenges to our graduate students and postdoctoral research fellows, interrupting and changing the pace and sometimes the course and focus of their research this past year. The pandemic caused many labs initially to push the pause button until it could be determined whether and how laboratory research could be safely conducted during the pandemic. Some were designated as essential personnel in the early months of the pandemic and kept our laboratory facilities running without interruption, ensuring the maintenance of cell lines and crucial experiments. Under the leadership of outstanding graduate program directors and faculty PIs, as well as the Associate Dean for Graduate Biomedical Education, Peter Espenshade, and the Associate Dean for Postdoctoral Affairs, Dana Boatman, the career paths of our graduate students and postdoctoral fellows have continued during the pandemic. In fact, we've really stepped up some of our career development programs under the leadership of Kate Bradford, the Associate Director for our Career Services in what's called our Professional Development and Career Office. This office has created an ecosystem that supports professional development and provides a variety of resources to graduate students and postdoctoral research fellows, including grant writing workshops, mock interviews, and one-on-one career counseling that many of our graduate students and postdoctoral research fellows did not have in previous years. And our medical students, graduate students, residents, clinical fellows, and postdocs continue to lead in a variety of ways with amazing service to the community, leadership of national student and trainee organizations, groundbreaking research, and awards and recognitions that are too numerous to mention here, not only because of time limitations, but also at the risk of overlooking some by highlighting others. I hope this gives all of you a sense of what's going on here at Hopkins for our students and trainees. It has been a challenging year, no doubt, and yet, in many ways, it has shown just how amazing Johns Hopkins School of Medicine is. Eleanor Roosevelt said, "A woman is like a tea bag. You can't tell how strong she is until you put her in hot water." Taking nothing away from the meaning of the quote, I would say that Eleanor Roosevelt's quote applies to our institution as well, and to all our students, residents, and fellows who have consistently demonstrated extraordinary strength through the most challenging of times. Thank you.
Thank you, Dr. Ziegelstein, for that important update on the School of Medicine. Our keynote speaker today, Dr. William Bill Moss, is a professor in the departments of epidemiology, international health, and molecular microbiology and immunology at the Johns Hopkins Bloomberg School of Public Health, executive director of the International Vaccine Access Center, and a deputy director of the Johns Hopkins Malaria Research Institute. He is a pediatrician with subspecialty training in infectious diseases and has worked in Ethiopia, Kenya, South Africa, Zambia, Zimbabwe, and India, among other countries. His broad research interests are the epidemiology and control of childhood infections in low and middle income countries. The specific focus of his current research is in understanding the epidemiology and control of malaria in southern Africa, the impact of the HIV epidemic on measles control and the feasibility of measles eradication, the use of serological surveys to guide immunization programs, and the care and treatment of HIV-infected children in rural Zambia. The COVID-19 vaccine is the gateway to returning to a new normal. It's the gateway to saving lives. Yet with the hope that it brings, there are challenges and many unknowns. Dr. Moss will share a detailed update on where we are with vaccine efficacy, distribution, and the impact of the pandemic.
I just got my first vaccine.
How you feel?
I feel good
Why'd you do it?
because I'm a chemo patient and I wanted to make sure that I was covered.
I feel like it gives me the first sense of normalcy in a long time, that there's light at the end of this crazy tunnel.
I'm really looking forward to my family being safe.
I got my first shot in December. I got my second shot January the 4th. I understand it's a personal choice and a personal decision, but how else are we going to attack it if we don't get the vaccine? So I think this is part of the solution.
It's my great pleasure to be with you today and to talk to you about vaccinating the world. This is one of the most important undertakings as we fight this global pandemic. We have not attempted in a very short period of time to vaccinate a large proportion of the global population. We have had eradication efforts, such as the smallpox eradication effort, where we attempted to vaccinate much of the world against smallpox. But that took us 10 years from the time of intensification of the smallpox eradication efforts to the actual last case in 1977. We have attempted to vaccinate much of the children of the world to eradicate polio. That effort was started in 1988 and we're still not done. We have made enormous efforts to vaccinate the children of the world against measles and other vaccine-preventable diseases, but despite enormous resources and efforts, have stagnated at about 85% coverage globally. So here we are facing a global pandemic where vaccines are one of our most important tools. And we're trying to vaccinate not just those in our country here in the United States, but people around the world, because until we reach high levels of vaccination coverage around the globe, we're still going to have the threat of this virus being transmitted and even being imported into the United States. I'm going to start by talking about the various COVID-19 vaccines, the COVID-19 vaccine landscape. And I just want to pause and reflect on how remarkable it is that now, just over a year into this pandemic, we have three safe and effective vaccines for which we have emergency use authorization in the United States. But there are multiple vaccines currently being used around the globe. And on this slide, which comes from the New York Times, shows that there have been around the world 8 vaccines that have been approved for use, 6 vaccines in early or limited use, and then 111 vaccines that are either in phase 1, phase 2, or phase 3 clinical trials. That is just remarkable. There is no other vaccine preventable disease for which we've had this large number of vaccine candidates. On the right, you can see some of the more commonly used vaccines around the world. The messenger RNA vaccines, and I'm going to talk a little bit more about those, particularly the Pfizer, BioNTech, and the Moderna vaccines. There are also a number of different adenovirus vectored vaccines. Obviously, the Johnson & Johnson vaccine being used in the United States, the Oxford AstraZeneca vaccine being used in much of the world, and then the Gamaleya vaccine being used in Russia and other countries, and the Chinese CanSino adenovirus vaccine. There are protein-based vaccines, particularly the Novavax vaccine, which we expect might receive emergency use authorization in the coming months. And then there are a number of inactivated vaccines, largely produced by Chinese vaccine manufacturers, particularly the Sinopharm and the Sinovac, that have had some problems in their rollout and evaluation. But it's actually an old tried and true method of creating viral vaccines. I'd like to talk to you a little about the science behind the mRNA vaccines, because I think this is quite a remarkable story. This is a figure that I take from a paper titled The Promise of mRNA Vaccines. And it kind of goes through the life cycle of a mRNA vaccine as it enters our cell, as the protein or antigen is produced, and as our immune system responds to that. And one of the main messages I want to get across is that there was a decade or two of work on these mRNA vaccines before we even had this pandemic. On the left side of this figure, and I'm just going to start on the upper left with NRM. Those are non-replicating mRNA vaccines. On the bottom are self-amplifying mRNA vaccines. That's a different type of messenger RNA vaccine. We currently don't have an authorized or approved vaccine that uses that self-amplifying mechanism. But for the non-replicating messenger RNAs, I want to highlight work that was done with Caitlin Carrico and Drew Weissman, who really made the fundamental scientific breakthrough in making available mRNA as a therapeutic tool or a vaccine. Now, messenger RNA is highly unstable, and so there are concerns that it would easily be degraded in the body, and so efforts were made to make synthetic mRNA. But this compound, these molecules, the synthetic messenger RNA, as messenger RNA in general, when it's extracellular, is highly immunogenic. And able to induce this strong immune reaction. It's somewhat similar to what many people feel after they get particularly the second dose of that of a Pfizer or Moderna vaccine. And what they were able to do, they were able to modify the molecule in a way that made it less immunogenic. And so this combination of modification and changes to the mRNA, making it more stable and making it less immunogenic, less reactogenic when it's injected, were fundamental discoveries prior long before the pandemic. The next thing that's happened, and this is shown in that little circle, is the messenger RNA is packaged as a nanoparticle within this fatty lipid coat. And that helps protect the messenger RNA, makes it more stable, and also allows it to be readily taken up by endocytosis into the host cell. And it's actually that fatty, that lipid capsule that some people have severe allergic reactions to following receipt of the Pfizer Moderna vaccine. That lipid nanoparticle with the genetic code or genetic recipe for the spike protein of the SARS coronavirus 2 is then taken into the cell where it's translated and produces a copy of the spike protein. And this is a very critical step as well, because that spike protein has to have the right conformation in order to be recognized by our immune system in order to induce a protective immune response should we be exposed to SARS coronavirus 2. And then you can see that protein is either expressed on the surface of the cell or released into the extracellular tissues where it's recognized by our immune system. So there was a lot of scientific work before the pandemic that went into really optimizing. So we were really poised to be able to manufacture these mRNA vaccines, which are a new vaccine platform, but they were very rigorously evaluated in clinical trials before the emergency use authorization. So what makes a successful mass vaccination campaign? Obviously, we have to have safe and effective vaccines, and we learn about those, we study those in the clinical trials. But in order to really be effective as a mass vaccination campaign, we have to have what I've called the 4 Ds. We have to have sufficient number of doses of a safe, effective vaccine. We have to be able to deliver those doses into the arms of people, and this aspect has multiple components to it. We need to be able to identify who's eligible to receive the vaccine. We need to have the ability to make appointments and schedule vaccination visits so people know when they're able to go and get a vaccination. We need to have enough vaccinators, enough people who can appropriately deliver the vaccine. And we have to have enough vaccination sites, places where people can go. And for a mass vaccination campaign, campaign, and a successful one, we need to have a wide variety. We need to move beyond, as we have here in the United States, beyond the traditional locations where vaccines are administered. These can be mass vaccination sites like sports stadiums, or we need to have mobile clinics to go into remote areas of the country or underserved communities to get the vaccines there. In addition to having sufficient number of doses and having the mechanisms to deliver those vaccines, we need to have adequate vaccine demand. And that demand is built by having trust. There's been a lot of talk about vaccine hesitancy and people who are skeptical to get the vaccine. And it's very important that we have the right messages first, that we actually listen to what the concerns are. What questions do people have? Why are they hesitant to be vaccinated? And then we have to have the right messages to provide the information that is needed. But equally important, we need to have the right messengers. And that's often community leaders. That can be healthcare workers, doctors, nurses, nurse practitioners. That can be church or religious leaders in the community. Those are the people who best understand the concerns of the community or a particular individual and are able to address them. And then the fourth D is having the appropriate data. We need to know who is being vaccinated. But we also need to set up the mechanisms for safety monitoring. Safety is evaluated through the clinical trial process, phase 1, phase 2, phase 3 trials. But we need to have safety monitoring after the vaccine is being widely used in communities. And we saw the value of that with the rare but serious clotting disorders that were seen after administration of the Johnson & Johnson vaccine. So what makes a successful mass vaccination campaign? Having the sufficient number of doses, being able to get them into arms, having the demand and building the trust for the vaccine, and having the data to be able to follow who's being vaccinated and the safety. Now, we've made enormous progress here in the United States. More than half of adults in the United States have received at least one dose. We've done particularly well because they were prioritized, those who were most vulnerable for severe disease, hospitalization, and death. For example, adults over 65 years of age. More than 2/3 have been fully vaccinated. But we've had inequities, vaccine inequities here in the United States. There are communities that are behind. Those can be communities of color or remote communities, remote rural communities that haven't had the access. But we're also seeing now, and I think this is really a pivotal point in our vaccination efforts here in the United States, where we've made tremendous progress, where we need to turn our attention to global COVID-19 vaccine inequities. And in this figure on the left side, you can see in that bar chart the percentage of the global population 18 years and older. And just starting from the bottom in that blue color, those are high-income countries. So 19% of the global population of global adults live in high-income countries. 37% in upper middle-income countries. 37% in lower middle income countries, and then that 7% in low income countries. That's the global population distribution by income level of countries. Now, if we look where these vaccines have gone, which countries have purchased, I mean, this won't be surprising, but 54% of all the vaccines have been purchased by the high-income countries, and you can see a very small proportion of the vaccines, COVID-19 vaccines, have been purchased by middle and low-income countries. And these are the global inequities in COVID-19 vaccine purchasing and access. And this is going to be an increasingly important problem as we move forward in our efforts to fight this pandemic. Now, the main mechanism to achieve global vaccine equity is something called the Access to COVID-19 Tools Accelerator, or the ACT Accelerator. And this has what are called 3 pillars, one directed to vaccines, I'll talk more about that, one directed toward therapeutics, and the other to diagnostics. And the pillar that's focused on getting vaccines, particularly to low and middle income countries, is called the COVAX facility. And this is led by the World Health Organization, Gavi, the Vaccine Alliance, and CEPI, the Coalition for Epidemic Preparedness and Innovations. And you can see here that they have attempted to raise, or wanted to raise, more than $18 billion to be able to provide 2 billion vaccine doses to low and middle income countries, free or at very low cost, so that those countries can begin to vaccinate their populations, particularly those who are at highest risk, the healthcare workers and the elderly. Now, to date, COVAX has only received about $6 billion in pledge, so they're behind. They've been able to get vaccines out to some countries, and I'll show you that. But we are behind. But this is the main mechanism, the COVAX facility, to address this global vaccine equity issue. Now, I want to tell you a little bit about our work at the International Vaccine Access Center. We celebrated our 10th anniversary in 2018, and I'm the executive director of this center within the Johns Hopkins Bloomberg School of Public Health. And it's been our goal to actually accelerate global access to life-saving vaccines. And we've done this obviously long before the pandemic. And we work along this evidence to policy to access continuum to try to support the rollout and really getting vaccines that are initially going to high-income countries to, in this case, focused on children, childhood vaccine preventable diseases, to low-income countries. And so we've kind of been in this business, if you will, of trying to get vaccine access to those who are most in need. And this is exactly the kind of thing now that we need for COVID-19 vaccines. So I won't be able to tell you all about what we do at IVAC, but I want to point out one website that we host called ViewHub, which is where we track new vaccine introductions into countries around the world. Again, the focus until quite recently has been on childhood vaccines, but we recently launched a new page on our ViewHub website to track COVID-19 vaccine introduction. And you can see here a global map. In green are those countries that have introduced COVID-19 vaccines, but you can see that there are still a number of countries that haven't even started to vaccinate their populations, particularly in sub-Saharan Africa, where there are a number of countries that have not introduced the vaccine. We also track the different vaccines that countries are introducing. Here, that kind of dark purple indicates countries that have introduced multiple different COVID-19 vaccines. But I want to highlight in that light blue is the Oxford AstraZeneca vaccine, which has really been, the go-to vaccine for the COVAX facility. Obviously, there have been some concerns raised about that vaccine because of the clotting disorders, similar to what was seen with the Johnson & Johnson vaccine. But this too is a highly safe and effective vaccine. And then there are vaccines, the Gamaleya vaccine made in Russia, and a number of the Chinese vaccines that are being used, particularly in these low and middle income countries. So this is one of our efforts to try to track global vaccine, COVID-19 vaccine introduction and use around the world. Another effort that I'm part of is the Johns Hopkins Coronavirus Resource Center, and many of you may be familiar with this, but this is a truly remarkable collaborative effort that involves the School of Johns Hopkins Medicine, the School of Public Health, the Centers for Civic Impact, the Centers for System Science and Engineering and the Whiting School of Engineering, and the Applied Physics Laboratory. So it's really a university-wide collaboration. Many of you have seen, if not all of you, have seen data presented from this Coronavirus Resource Center, particularly on tracking cases and deaths around the world. I'm part of the management team on the vaccines page, which we launched a couple months ago. And here we're really trying to track global coverage with COVID-19 vaccines. So not just introductions, but what proportion of the population is actually immunized. And this is a striking map with the darker color indicating a higher proportion of the population vaccinated. And you can see that there are many areas of the world in which there's very low COVID-19 vaccine coverage. And so this is a big challenge going forward about how we achieve this global vaccine equity. And it's particularly important, obviously, in a pandemic, because as long as there's virus circulating in other parts of the world, we here in the United States are at risk of importations and possibly with variants that can escape the immunity that we've achieved through vaccination. Now, there's been a lot of thinking about COVID vaccine equity, and I just want to touch on briefly some aspects of this. Before vaccines were available, the Center for Health Security published an interim framework for COVID-19 vaccine allocation and distribution in the United States, and then the National Academies of Sciences published a framework for equitable allocation of COVID-19 vaccine, again, focused in the United States, but with a vision toward global equity. I just want to mention a few elements of this framework, and basically they laid out a goal to reduce severe morbidity and mortality and negative societal impact, established allocation criteria, and then came up with 4 allocation phases, going from those at highest risk of severe disease and exposure to those at lower risk. Underlying this were ethical principles of maximum benefit, equal concern, and mitigation of health inequities. And this kind of thinking, this framework, is really important, not just for thinking about inequities within the United States, but thinking about global inequities. And so their 7th and last recommendation coming out of this National Academies report was to support equitable allocation of COVID-19 vaccine globally. And here they were really calling on the United States to play an important role in achieving global vaccine equity. And they pointed out, again, this was before any vaccines were available. They called on the United States government to opt into the COVAX facility, which the U.S. government now has and contributed roughly $6 billion. They called on the United States to deploy a proportion of its vaccine supply for global allocation. Recently, the Biden administration said they're going to donate 60 million doses of the AstraZeneca vaccine into the COVAX facility to be distributed, but I think the United States needs to do more. And then lastly, engage with and support the World Health Organization and its member states. So I thought this is a call to us here in the United States to really support equitable allocation of COVID-19 vaccines globally. Now, I want to end up by coming back to the work of the International Vaccine Access Center and just highlighting how in the past, how long it's taken from vaccines to reach 50% of the population in a high-income country to 50% of the population in a low-income country. You can see here in the box on the right, for hepatitis B vaccine, that took 19 years. For the Haemophilus influenza type B vaccine, 10 years. And then, in part, due to the efforts of the International Vaccine Access Center through a project called PNEUMO-ADAP, for pneumococcal conjugate vaccine for 4 years. But we don't have the luxury to really wait many years to achieve global equitable equity in COVID-19 vaccine allocation. So what can we in the United States do? Well, there's been a lot of discussion about making our excess doses available, as I mentioned with the AstraZeneca vaccine. But we as a country have purchased many more vaccine doses than we actually will need. And so I think the United States can redirect some of those vaccine doses. We can support the manufacturing of additional doses. And the Biden administration, for example, helped broker an agreement between Merck, one pharmaceutical company, and Johnson & Johnson to get Merck to actually help scale up the manufacturing of the Johnson & Johnson vaccine. So there can be more of these arrangements between pharmaceutical companies. There's been a lot of talk about loosening some of the patent and intellectual property restrictions to allow other vaccine manufacturers to be able to make vaccines for the global market. Now, making these vaccines is not trivial, particularly the mRNA vaccines, because these are a novel vaccine platform, so they would really require rebuilding vaccine manufacturing plants, but we need to do more to increase that vaccine supply. So if we come back to the 4 Ds of a successful vaccination campaign, mass vaccination campaign, the biggest bottleneck right now is having sufficient number of doses, but we also need to ensure that countries are able to deliver those doses into arms, and that they're able to do the public health messaging to create the demand and then create the data management system so that they can track who's being vaccinated and monitor for safety signals. So Johns Hopkins Medicine and Johns Hopkins University as a whole is playing a really important part in not only COVID-19 vaccine rollout here in the United States, but in thinking about how we can really pivot and focus our efforts on achieving global COVID-19 vaccine equity. Thank you for your attention.
Thank you so much, Dr. Moss, for that extraordinary and thorough presentation. We have a few thoughtful questions for you from some of our alumni. The first question is, what can we expect for future seasonality and changing vaccine requirements for COVID-19?
Yes, I mean, these are really important questions, and I don't think we quite know yet how SARS coronavirus 2 is going to behave in terms of seasonal transmission. I have no doubt that it's going to be with us for a long time. We're not going to eradicate this virus in the near future, certainly. But whether it's going to be more seasonal transmission like we see with influenza viruses, I think it's still too early to tell. But we may need booster doses, and I think this is a very important issue. There are really 2 reasons why we may need additional doses of vaccines. One is if the duration of protective immunity is short. So if there's waning immunity, we would require then booster doses to obviously boost that immunity and keep us protected. The other reason for additional doses is the emergence of variants of concern, and particularly variants for which our vaccine-induced immunity is no longer effective. And so we may see booster doses in the future that basically contain the same virus that we've been vaccinated with before. Or as I anticipate, we may see kind of what we might call multivalent vaccines that actually target the original virus strain, as well as some of the newer variants of concern.
Well, that answered the second question. So I have another question after that. What is the likelihood of reaching herd immunity in the United States, and what are the consequences of not reaching it?
Yes, this too is a very frequently discussed topic. And the way I like to address this one is first to address any misconceptions about herd immunity, because I think we sometimes talk about it as if there's some magical threshold that we need to achieve with vaccination coverage, and then all of a sudden the virus is going to go away. And that's not really how herd immunity works. And it actually has some subtleties to it that I think get missed. But basically, what herd immunity refers to is that the probability of an infectious individual coming into contact with a susceptible person just gets really low because there are so many vaccinated and protected people in the population. And so if we just kind of follow the basic rule of thumb, what we people talk about is a herd immunity threshold maybe of 70%, 75%, 80% of people actually immune. That's not people vaccinated. The vaccine's not 100% effective, so our vaccination coverage needs to be higher than that. And if we have these more contagious variants, then that herd immunity threshold gets higher. But it also is a function of how frequently people come into contact with one another. So that herd immunity threshold is not kind of one value across the United States. It's higher in cities, for example, than in rural America. So there are kind of nuances here. I think it's going to be difficult for us to achieve kind of true herd immunity, if that even exists. What I see as the end game is, first of all, we want to reduce hospitalizations and deaths. That's our most important goal. And I think we're beginning to certainly see evidence of that. I think our end game is going to be not that we reach some herd immunity threshold and the virus goes away, but we're going to be living with this virus. And so we're going to need to have systems to be able to detect newly infected individual, isolate them, do the contact tracing and quarantine the contacts, and control these kind of hot spots, or almost, you could almost think of it like little forest fires around that are going to pop up that we're going to need to kind of jump on and control.
That was a great answer. So along those lines, so let's say we do keep, COVID-19 is quiescent for a while. Do you think we should expect other pandemics in the near future?
Yes, I do think we're certainly at risk for new emerging infections. There's no doubt about that. We continue to see emerging infections. And what these emerging infections are, and whether that's a bird flu, a Zika virus, an Ebola, or a SARS or MERS, these are what we call zoonotic infections. And these are viruses that jump species, jump from animals to humans. And so we're certainly going to see emerging infections in the coming years. Whether one of those pathogens kind of ignites and becomes a pandemic like SARS coronavirus 2 is, requires that virus then adapt quickly to humans and be able to be transmitted from person to person. We will see pandemics in the future, but whether it's 50 years, 100 years, 10 years, I don't really know. But what I can guarantee is in the next few years, we're going to see new emerging infections.
It's too bad. Yeah. Do you have time for 2 more questions?
Sure.
Okay, terrific. So this is a question from somebody whose native country is Costa Rica, and they worked there for 25 years in the Ministry of Public Health. And they say that they're having a severe outbreak, and this was as of April 29th, which appears to be affecting now mainly people younger than age 60. With few underlying risk factors. Do you think that the AstraZeneca vaccine will do the job appropriately without many adverse reactions, mainly described in younger women? That's part 1. And part 2 of the question is, would you mind commenting on the Novavax vaccine, since there's very little information released about it?
Yeah, these are somewhat complex questions, but So the AstraZeneca vaccine is a very safe and effective vaccine, and as I said, it's the vaccine that's actually being used in more countries around the world than any other vaccine. It's an adenovirus vectored vaccine, meaning that the genetic recipe for the spike protein, instead of being as messenger RNA, is inserted into an altered adenovirus, another type of virus that actually can't replicate, is made such that it can't replicate. So it's just another way of delivering that genetic recipe into our cells to make the spike protein. It is true that rarely some people have had these severe clotting disorders that we saw here in the United States with the Johnson & Johnson vaccine. But the benefits of these vaccines, those are very rare adverse events, and the benefits outweigh the risks. Now so in general, yes, my answer would be yes. I think the AstraZeneca vaccine could help reduce hospitalizations and deaths, certainly in Costa Rica, as in in other countries. It does have. I'll say the one caveat about the AstraZeneca is that it does seem to have reduced protection against what's called the B1351 variant that was first identified in South Africa. And South Africa has opted not to use that vaccine because of that reduced efficacy. So I would say, in a country where, if there were a country where that were the dominant variant, there you might see reduced protective efficacy against mild disease because of those variants. Now, the Novavax vaccine is a different type of vaccine platform. It's what we call a protein-based vaccine. So instead of injecting the genetic recipe for the spike protein, you actually just take the spike protein, and it's configured in a certain way in a nanoparticle. There's what we call an adjuvant added to it, which helps stimulate the immune system. And so the data from those phase 3 trial are still being collected. So we haven't seen much of the phase 3 trial preliminary data. But I think things look I've heard that both the safety and the efficacy look good with that vaccine. So I expect that we may see an emergency use authorization for the Novavax vaccine in the coming months. And I'll just say, it may not play a big role, at least initially in the United States, but I think the more vaccines we have available to us to fight the global pandemic, the better. And just to say that the Pfizer and Moderna vaccines do require very cold storage, so that's hard to do in many low and even some middle income countries. So these other vaccines, the adenovirus vaccines, but a protein-based vaccine like the Novavax vaccine may just be a lot easier to handle in many low and middle income countries.
So this is my own personal question, but so as Europe opens up this summer, do you think it's safe to travel there? Would you travel to Europe?
Yeah, so it's a function, these kind of things are, there's obviously some risk. I wouldn't say the risk is zero, but it's going to depend obviously on your own kind of vaccination status. And I don't think you'd travel to Europe if you were unvaccinated. So that places you, you're very highly protected. These vaccines are not 100%, but they're really good about protecting against, severe disease. And then, the local transmission, what the level of local transmission is. So if we're seeing transmission come down, that would obviously lower the risk. And then the types of public health measures that you take. So I would say in a country that's not in a raging, outbreak, high levels of transmission, with a fully vaccinated or immunized person who's careful when they go, I think that would be safe. Did I hedge too much?
No, that was good. That was good. Well, we're all hedging because we don't know the answer. So no, I think that was terrific.
Exactly.
So I have one final question. This is a little loaded, but so how can we as scientists convince anti-vaxxers to get vaccinated and that COVID is not a hoax?
Yeah. So obviously a very big problem, a very big issue. So the way I think about this is first is to well first to understand that vaccine hesitancy is really a spectrum, and you know there are people who are really adamantly against vaccines, COVID-19 vaccines, vaccines of any type, and it's not clear to me that any type of persuasion information is going to change their mind, but that's a relatively small proportion of the population, and most people, kind of fall along that continuum, with many people in the middle. And so I think the first thing is to listen, to try to understand what their concerns are, what their questions are. There are common questions and concerns. There are, many people in the United States are concerned about the safety of these vaccines. And many people feel that they may have been rushed. They're new vaccines. They are new vaccines. But what I tried to highlight in my talk, in part, was that there was a lot of scientific work that went behind the mRNA vaccines before we even got to this point. And so I think they're trying to have people understand that there were no corners cut. There are reasons why the vaccines were able to be evaluated very quickly, in part because we were in the middle of a pandemic, so it's very easy to do a phase 3 trial and accumulate cases when you're in the midst of a terrible pandemic. Usually that takes many years to do. So the first thing is to understand concerns. My kind of simple framework for kind of thinking about much of vaccine hesitancy is that people tend to overestimate the risk of the vaccine and underestimate the risk of the disease. And so their risk-benefit calculus is different, is altered by that. So you try to provide, correct misinformation and disinformation. One has to be careful about doing that, but you don't want decisions being made on faulty information. And as I said, it's equally about the messenger as the message. And so, people who are trusted, and those can be a family member sometimes, but it can be a healthcare provider. And it can be, as I said, community and religious leaders. So, sometimes I think public health officials and certainly politicians probably should politicians maybe in general should kind of lay low and let the community leaders talk sometimes, because they understand the concerns best.
No, that was a great answer. Very diplomatic.
I'm around COVID. What I would love to do is, those people who think COVID is a hoax need to be brought into an intensive care unit full of COVID-19 patients.
Yeah.
Yeah.
I know some of my kids, friends' parents died. So that makes it real.
Yeah. So exactly. If something's happened, personally.
So thank you again, Dr. Moss. It was such an intriguing presentation, and the work that you lead is inspiring. It gives us hope, and it makes our hearts swell with pride for Johns Hopkins.
As surely as day follows night and winter melts into spring, we keep going. Somewhere down deep in our nature, we will seek and find the strength, stamina, wisdom, and purpose to keep going. Tomorrow may be uncertain, but as long as this small blue planet turns, tomorrow will come, and with it, the promise of a new day of possibility and hope for our patients and for each other. And with that, we will keep going.
Thank you, Dr. Moss, for that intriguing presentation. The work that you lead is inspiring and is truly saving and changing lives. A special thank you to each of you for joining us today for the 2021 School of Medicine Reunion Symposium. We hope you will participate in the other programs offered throughout the weekend and enjoy the opportunities to connect virtually with each other. The award and portrait presentation will begin shortly at 6:15 p.m. Eastern Time. We hope you'll tune in to watch as some of your fellow alumni are honored. Thank you again for joining us and have a good evening.
Thank you for joining us today. I want to welcome you to the 2021 Award and Portrait presentations. I'm so glad that we could do this. Because of the pandemic, we had to cancel last year's ceremony. So this is the first time we've done this since 2019. Today, we will honor a group of 29 alumni clinicians, educators, and researchers who have greatly influenced medicine and science. Some of these women and men spent their careers at Johns Hopkins, while others studied here and then migrated elsewhere. I'll have some help today. Dr. Diane Olinsky, president of the Johns Hopkins Medical and Surgical Association, will be presenting the Distinguished Medical Alumni Awards for the Johns Hopkins Medical and Surgical Association. Along with several others, our Pathology Department Director, Dr. Ralph Ruban, will present the Johns Hopkins University Alumni Association Awards. During the ceremony, we will be unveiling the portraits of people who have contributed significantly to the school and the institution. These paintings will become part of our collection of more than 300 portraits, which honor the greatest clinicians, educators, scientists, leaders, and philanthropic supporters who have made a major difference here over their careers. I would like to take a moment to recognize the two fantastic artists who have created the 5 paintings we will unveil today. Between them, Peter Eggerly and his daughter Lisa have been responsible for more than 50 Johns Hopkins portraits over the years. As you'll see today, they are extremely good at what they do. Now, I would like to turn things over to Dr. Olinsky, who will present the Distinguished Medical Alumni Awards. Diane?
The Distinguished Medical Alumni Award honors alumni of the School of Medicine and the Johns Hopkins Hospital who have demonstrated excellence and achievement through their personal and professional accomplishments. This year, the Johns Hopkins Medical and Surgical Association, the body that represents all alumni, including graduates and former trainees, awarded 8 recipients, and I'm honored to introduce them to you today. Dr. Eli Adachi is a tenured professor and a former dean of medicine and biological sciences at Brown University. He has been the recipient of continuous National Institutes of Health funding from 1985 to 2005, inclusive of a USPHS Research Career Development Award. Dr. Adachi is presently a member of the Advisory Council of the Hastings Center Bioethics Research Institute and chair of the Medical Executive Committee and the Medical Advisory Council of the Jones Foundation for Reproductive Medicine. Dr. Richard Conti served on the cardiology faculty at Johns Hopkins from 1968 to 1974. He is Professor Emeritus of Medicine at University of Florida Health. Internationally recognized as an expert in cardiovascular medicine, he served as president of the American College of Cardiology and has been recognized around the globe for his scholarly work, which includes over 700 scientific papers, abstracts, book chapters, and books. Dr. Keith D. Lillimo received his medical degree at Johns Hopkins, staying for surgical training, and served on faculty for 17 years before going to the Indiana School of Medicine as the Chief of Surgery and Chairman of the Department of Surgery in 2003. After serving in that capacity for 8 years, he accepted the job as Chief of Surgery and Chairman of the Department of Surgery at the Massachusetts General Hospital. Dr. Donna Magid is a devoted educator and mentor. As director of both the Johns Hopkins University School of Medicine Horizontal Strand in Diagnostic Imaging and undergraduate medical education and radiology, she develops and oversees educational programs and curricula to ensure a firm foundation in and safe, effective use of imaging in medical practice. Dr. Magid is also recognized nationally and by the students for intense involvement with career mentoring, emphasizing precise, appropriate use of medical English and the nonverbal aspects of professional demeanor and comportment. Dr. Fred Merkel performed pioneering work in liver and pancreatic transplantation at the University of Minnesota, where, with 2 colleagues, he performed the first human pancreatic transplant in December 1966. His contributions led to Medicare coverage of kidney transplants in 1974 and helped develop organ sharing between programs in America, Europe, and the Middle East. He served as president of the American Society of Transplant Surgery and has performed 142 visiting professorships around the world. Dr. Joseph Moore is currently a professor at Duke Cancer Center. There, he has earned both the Leonard Tao Humanism in Medicine and Distinguished Faculty Awards. However, he may best be known as the cancer physician for the college basketball coach Jimmy Valvano, who died of metastatic cancer. Dr. Moore worked with the Valvano family and ESPN Sports Network to establish a major cancer research charitable foundation in 1993, which to date has distributed more than $150 million to cancer research. Dr. Srinivas Sada has made countless contributions to the field of ophthalmology. One of his greatest contributions has been helping to develop artificial intelligence diabetic retinal imaging analysis software, recently approved by the FDA and only the second of its kind to be created. His research has been consistently funded by the National Institutes of Health and multiple private organizations, and he served as principal investigator on over 30 major clinical trials. Dr. Joseph Cerletti is a national leader in academic plastic surgery whose accomplishments span leadership, innovation, education, and clinical excellence. His contributions have had immeasurable impact on national plastic surgery, the education of several generations of plastic surgeons, and most importantly, patient care worldwide.
What makes me the proudest to be an alumnus of Johns Hopkins is its legacy of excellence, which is recognized the world over. And since excellence is all about people, that is, after all, where it all begins. My first recollection may well have been that of A. McGee Harvey, whose user-friendly textbook of medicine was all I required as a medical student. Closer to home, of course, was the legacy of Howard and Georgiana Jones, with whom I had the privilege of serving my Hopkins Fellowship. Innovators of the highest order and ultimately the originators of in vitro fertilization in the United States, the Joneses were classic Hopkins material. Nothing but the best.
I was asked what makes me most proud to be an alumnus of Johns Hopkins. The teaching skills of the faculty, both basic and clinical, were extraordinary, but in particular, I would like to mention a special few. The first individual I'd like to mention is Lee Cook, who I worked with as a medical student, who eventually recruited me to the University of Florida to be chief of cardiology in 1974. Dick Ross, who was then chief of cardiology at Hopkins when I was an intern, resident, fellow, and faculty.
Being the recipient of the Johns Hopkins School of Medicine Distinguished Medical Alumnus Award is truly one of the greatest honors of my career. Though it may not be known to most, I entered Johns Hopkins School of Medicine through the back door as a transfer student after graduating from the then 2-year medical school at the University of South Dakota. I think it's fair to say that the opportunity to enter the tremendously stimulating academic environment, and particularly the great culture of excellence in the Department of Surgery at Hopkins under George Zeidema and then John Cameron, provided me with an opportunity to achieve goals I could never have dreamed of as a farm kid from South Dakota. I want to thank my teachers, my colleagues, my trainees, and my many friends from my almost 30 years at Hopkins, many whom I remain close to this day. So when asked what makes me most proud to be an alumnus of Johns Hopkins, it is a simple answer, is that Hopkins provides an unmatched opportunity to build relationships and friendships that last a lifetime. My thanks to the Hopkins Medical and Surgical Association for bringing us all together for these great events. I hope we can all do this in person next year. Thanks again to all.
From the first day of medical school, Hopkins has given me a lifelong opportunity to respond to the Martin Luther King quote I've always found the most compelling, which is, life's most persistent and urgent question is, what have you done for others? At Hopkins, I found a niche educating, mentoring, and hopefully enabling our amazing students and residents to excel. In the normal flow of time, they first join us, and then if we've done it right, they surpass and eventually replace us, building on and contributing back to their Hopkins foundations, whether here or elsewhere. I am extremely appreciative of and honored by this recognition. Thank you.
Thank you so much for this wonderful award. I didn't expect it, but I certainly accept it with great gratitude. Johns Hopkins was the place where I started, where my whole life in academic surgery and in transplantation began. I loved the wonderful professors and teachers that we had, the way they were able to inspire us. Sometimes I would sit at the edge of my seat. The lectures were so exciting and interesting. And I had wonderful classmates, and we learned so much. We certainly learned how to be good doctors. We were taught how to how to look and listen at patients, listen with patients, how to handle them, how to show them with kindness and understanding, and how to begin to take them off to success there with medical therapy. The whole time at Hopkins was a complete joy, and I couldn't be happier. Thank you very much for this award.
Every day, I am proud to be an alumnus of the Johns Hopkins Medical School and the Osler Medical House staff. I was taught there a tradition of excellence in patient care, teaching, and research, and I've carried that forward for the last 45 years at Duke University Medical Center, where I am full professor. I want to give a shout out to my classmates from the class of 1970. They were extraordinary, still are. And I want to thank the Johns Hopkins Medical and Surgical Society for this wonderful honor, which is unbelievably appreciated. And I thank you very much.
To be recognized by the Johns Hopkins School of Medicine as a distinguished medical alumnus is a tremendous honor for which I am deeply humbled. I'm so proud to be an alumnus of the institution, which is not only the recognized leader of medicine worldwide today, but also truly the birthplace of modern medicine. And so for me personally, to be able to train at Hopkins for medical school, then residency, fellowship, and then to join the faculty, that really gave me the foundation that has truly been inspiration for my entire career in academic medicine. And so I think being a Hopkins alumnus, you feel an incredible responsibility to take this amazing training and then make an impact on your field moving forward. And so it's all about paying it forward. And to this day, whenever I come back to Baltimore to visit the campus, I get chills when I walk under the dome, thinking about the traditions of all of the leaders of medicine who've walked through these halls in the past. And so I'm truly grateful for this amazing honor.
I am both proud and humbled to be an alumnus of what is without doubt the greatest medical institution in the world, Hopkins Medicine, and its tradition of excellence in patient care, research, and education. My time at Hopkins had an immeasurable impact on my career as I, throughout my career, sought to live up to these high ideals that are the core values of Hopkins Medicine. I cannot even begin to fully express my sincere gratitude. And again, I remain incredibly humbled to receive this Alumni Achievement Award. From the bottom of my heart, I want to thank all of you.
It is my honor today to present the portrait of Dr. Tina Chang, who served from 2016 to 2020 as the director of the Department of Pediatrics and Pediatrician-in-Chief of the Johns Hopkins Hospital. Dr. Chang was recruited to Hopkins from George Washington University in 2002 to become the Division Director of General Pediatrics and Adolescent Medicine. Dr. Chang's academic career focused on improving the health of vulnerable children, adolescents, and families through community-based interventions. Tina's work demonstrated that social determinants such as poverty, poor education, housing, marginal nutrition, violence, and racism have profound impacts on child health that last over the entire life course. She helped create innovative research and clinical centers within the Harriet Lane Clinic, the Latino community at Bayview, and the Baltimore school system. Her work demonstrated that academic pediatrics could intervene in the community where our families live to enhance the health of children, their families, and improve the effectiveness of our medical systems over entire lifespans. Because of her national recognition and leadership in this area, she was promoted to professor at Johns Hopkins in 2004 and elected to membership in the National Academy of Medicine in 2017. Tina Chang was a transformative director of pediatrics at Johns Hopkins. By transformative, I mean not simply that she was the first female director of the department, but that she expanded the tripartite missions of the department to encompass an understanding that the major determinants of child health lie beyond the diagnosis and treatment of disease. Most importantly, Tina is a phenomenal mentor and role model. She is known for expanding the pipeline and diversity of pediatric trainees, mentored dozens of interdisciplinary researchers, many from underrepresented minorities, and many more clinicians who have gone on to be leaders in health sciences, services, innovations, and community health. In her own words, pediatricians can do more than care for sick children. They have the power to change their lives, to preempt injury and illness. Tina, congratulations and thank you for your leadership, your mentorship, and demonstration of how much more we can do for the health of children in our community.
It has been a distinct honor and privilege to be a faculty member at Johns Hopkins University, a leader of the Johns Hopkins Children's Center, and the 9th director of the Department of Pediatrics and a child advocate. Our vision that Johns Hopkins Pediatric is the birthplace of modern pediatrics and the future of health speaks the truth. This is a place of many historic firsts in pediatrics and continues to innovate and create the future for child health. I believe deeply that children are the foundation for lifelong health, and we do incredibly important work for all children in our community and globally. I've often said that children are 9% of US healthcare spending and 100% of our future. The tripartite mission of clinical care, research, and training the next generation of child health professionals is in service to that future. I am forever grateful for being part of this vision with all of you and for the honor of this portrait on behalf of the children, adolescents, and families that we serve.
Hi, I'm Ralph Ruban, a proud member of the class of 1985 and a member of the university's Alumni Council since 2016. The university's Distinguished Alumni Award honors alumni who have typified the Johns Hopkins tradition of excellence and have brought credit to the university by their personal accomplishments, their professional achievements, or humanitarian service. Today, the Johns Hopkins Alumni Association is honoring 11 award recipients. Dr. Michael Brunt is a professor of surgery at Washington University in St. Louis and is a recognized leader and clinical expert in laparoscopic, endocrine, and hernia surgery. He also, and this must be a fun job, is the team surgeon for the St. Louis Blues, and he has a nationwide referral practice for collegiate and professional athletes with sports hernias. As passionate about education as he is about research, Dr. John Lorsch worked to reform the curricula for graduate and medical education. He became the director of the National Institute of General Medicine Sciences in August of 2013, which supports basic research that lays the foundation for advances in disease diagnosis, treatment, and prevention. Dr. Mary Lynch is a professor of ophthalmology at Emory University School of Medicine. Her research has focused on innovative ways of dealing with difficult problems in glaucoma. She wrote early and classic papers on side effects from beta blocker eye drops, on the surgical treatment of malignant glaucoma, and on the 360-degree suture trabeculotomy for the treatment of congenital glaucoma. An internationally recognized physician scientist, Dr. Jonathan Simons, is the president and chief executive officer of the Prostate Cancer Foundation. He leads this foundation with passion and intelligence. Prior to taking on his current role, Jonathan made original contributions to human prostate cancer research here at Johns Hopkins University and later at Emory University. Dr. Gary Darmstadt is a leading scholar, innovator, and one of the most important voices worldwide on strategies and interventions to save the lives and improve the health and development of young children in low and middle income countries. He trained in pediatrics at Hopkins and led the creation and implementation of global research for the Saving Newborn Lives initiative at Save the Children, funded by the Bill and Melinda Gates Foundation. Dr. Brian Garibaldi is a top respiratory and critical care doctor. Very presciently, he helped to design a specialized ward to treat the most contagious patients in the country. The Hopkins Biocontainment Unit opened in response to the Ebola outbreak in 2014 and served as a model for the countless biocontainment units created in response to the COVID-19 pandemic. Dr. William Kaelin is the 2019 Nobel Prize in Physiology or Medicine recipient. The 2019 Nobel was awarded jointly to Kaelin, Sir Peter Ratcliffe, and Dr. Greg Zemenza for their discoveries of how cells sense and adapt to oxygen. Dr. Kaelin received his MD from Duke University and was a house officer and chief resident in internal medicine at Johns Hopkins Hospital. Dr. Tom Koenig has spent the last 35 years at Johns Hopkins. In addition to his contributions to the Department of Psychiatry, Tom served as Associate Dean for Medical Student Affairs over 16 years. Tom is an extraordinary human being. He has advised nearly 2,000 medical students, shaping the next generation of healers and leaders in medicine. He is retiring this year, and his impact as an advisor and passionate advocate for medical students will be felt for generations. Dr. Lisa Maragakis serves as the Executive Director of the Johns Hopkins Hospital Biocontainment Unit and as Incident Commander for the Johns Hopkins Medicine COVID-19 response. Dr. Maragakis has been at the forefront of the COVID-19 pandemic and has served as the face to Johns Hopkins Medicine's response to this healthcare crisis. Whenever there is a question at Hopkins or nationally on what to do in response to a challenge posed by the pandemic, Lisa has the answer. Dr. Mario Molina's service to Johns Hopkins Medicine is unparalleled. He has served as a university trustee and chair of the Osler Advisory Board. The Molina Scholars Program has generously supported the physician-scientist pathway in the Osler Medical Residency Program. Dr. Molina has funded 3 professorships in the School of Medicine. Dr. Molina's vision and support of the physician-scientists will have a lasting impact. I should also note that Dr. Molina is an expert in medical history and has helped the School of Medicine celebrate and preserve our history. Dr. Susan Shuren was Deputy Director of the National Heart, Lung, and Blood Institute at the National Institutes of Health. As Deputy Director, Dr. Shuren represented the Institute in a wide variety of activities across the NIH and the Department of Health and Human Services. Through the support of research from bench to bedside, Dr. Shuren led the Heart, Lung, and Blood Institute's efforts to transform new scientific knowledge into tangible improvements in health.
Thank you so much. It's an incredible honor to be a recipient of this Hopkins Alumnus Award. I'm so proud to be a graduate of an institution that has such a rich and proud history that really redefined medical care at its inception and continues to do so and set the standard for excellence in medical education, and also for the incredible clinical experience that I had as a medical student at Hopkins and how well this prepared me for residency training. If not for Hopkins taking a chance on me as a young student from a small town and university in Mississippi, I would not have gone into academic surgery and would not be where I am today. And for that, I am forever grateful. Thank you.
So the thing I'm most proud of my time at Hopkins is my interactions with the students. The students at Johns Hopkins are truly extraordinary, and it was really an honor to be able to play a role in launching their careers.
I spent 13 years in Baltimore with Johns Hopkins. I was an undergraduate, I went to medical school, I was on the house staff, and I did my fellowship there. And all along the way, I met tremendous mentors who took me under their wing and supported me and led me to believe that my ideas could have value. When I was an undergraduate, I was the second class of women to come to Hopkins. And when you went to the Cooley Center, the Denton Cooley Center, there was no women's bathroom there. That's how, or women's locker room there. That's how early it was in the co-ed time. And so I thought maybe we could start a sports team? And they said, sure. And we started the women's swimming team. And that's the way Hopkins is. It gives opportunity to its students and supports them and makes them believe that their ideas can take flight.
It's a profound honor and privilege to receive this recognition from the Johns Hopkins University. It's been a privilege to be a Johns Hopkins medical student, postdoctoral fellow, clinical oncology fellow at Johns Hopkins, and a 12-year faculty member in urology and in oncology, and have a really dream physician scientist career at Johns Hopkins, and a profound privilege to have mentors like Dr. Donald Coffey. The Hopkins gave the world the principles and practice of medicine from Osler, but it also gives the world the principles and practice of leadership for American medicine, just by example. So on behalf of my entire family and me, we're just so grateful for our time at Hopkins, this award, and to the entire Johns Hopkins family, God bless.
I have had 2 stints at Johns Hopkins. The first was as a pediatric resident from 1989 to 92. I was extremely excited to come to Hopkins and to be immersed in the great tradition of excellence in the School of Medicine. I got to learn pediatrics from giants in the field like Frank Oski and Kathy DeAngelis, and also from my fellow residents who went on to do great things in their own right. One of my early attendings on the infant service was Dr. Matu Symposium. He became a lifelong mentor and a very close friend. And he and Bob Black recruited me back to Johns Hopkins into the Bloomberg School of Public Health. And there I got to found and direct the International Center for Advancing Newborn Health. I'm really proud of the collaborative multidisciplinary team that we built and the research that we conducted throughout Asia, also in Africa, examining ways to improve survival and health of newborns through empowering families and community health workers. My time at Johns Hopkins profoundly shaped and changed my thinking, my capabilities, my relationships with people in the field, and my opportunities for a lifetime. I'm so grateful. I'm so thankful for the great honor of being an outstanding alumnus of Johns Hopkins.
I'm incredibly proud of the way the Hopkins community has stepped up in our response to COVID-19. From the people on the front lines who've been providing care around the clock to patients with COVID and other patients who need care during these difficult times, to the incredible pace of scientific research that has added to our knowledge about the pathobiology of COVID, but also the way that we can treat these patients better, to the premier role that Hopkins has played in providing actionable and accurate information so that people can make informed decisions about their own response to COVID-19. It has truly been an honor and a privilege to be part of that response and to be part of the Hopkins community.
I want to thank you so much for this Johns Hopkins Distinguished Alumnus Award. I'm thinking back to July 1, 1983, when I walked into the Johns Hopkins Hospital for the first time, entering on the Broadway Street entrance. And I remember being both excited, but frankly a little bit terrified. I think my heart rate was about 130. But I knew immediately that no matter what else I did in my medical career, that no one would ever be able to take away from me the fact that I had trained at Johns Hopkins. So this award is especially meaningful to me. Thank you so much for this recognition. I wish I could be there in person with you.
Thank you all so much. This means an extraordinary amount to me. But I have to admit, it feels a little odd being recognized for doing something that you absolutely love. In addition to being able to practice psychiatry at one of the top medical centers in the entire world, I've also had the great good fortune of working with medical students at Hopkins, both as a clerkship director and as a student affairs dean. And I have absolutely no doubts that they will make the future of medicine even brighter than it has been for all of us. Thanks again, and please stay well.
Thank you so much. This award means so much to me, and I am proud and extremely honored to be an alumna of Johns Hopkins University, primarily because of the extraordinary people whom I have had the privilege of calling my classmates, teachers, mentors, colleagues, and friends. These amazing individuals and the Johns Hopkins University inspire and challenge me to excel and strive to be better every day. And I have benefited from lifelong learning here through medical school, clinical residency, fellowship training, and the School of Public Health, as well as countless other opportunities to learn and grow. In particular, I've never forgotten the lessons of equanimitas learned on the Osler Medical Service, and I hope that I am able to embody this ideal in my work every day. It's truly a privilege to be even a small part of the Johns Hopkins University's amazing history and extraordinary story of scientific discovery, clinical care, teaching, and service to our community and to the world. Thank you so much.
I'm very proud to be an alumnus of Johns Hopkins and to receive this award. I think former Dean Tommy Turner summed it up best when he said the thing that makes Hopkins so special is a heritage of excellence. A heritage that began with Osler, Kelly, Welch, and Halstead, and extends down to the present day in terms of teaching, research, and patient care. For example, during the recent coronavirus pandemic, Hopkins was the trusted source for information about coronavirus. So for these reasons, I'm very pleased to accept this award, proud to be part of Johns Hopkins and to support the mission.
I am grateful to be a Hopkins alumna because I treasure my amazing teachers like Bill Zinkum, Sam and Patricia Sharash, Helen Tauzik, Guy McCann, and my colleagues who became lifelong friends like Kathy DeAngelis, George Dover, and Gary Goldstein. Hopkins prepared me for a career enriched by a passion for discovery, wonderful models of leadership, and close relationships with patients and families. Hopkins offered inspiring examples of creative scientific curiosity and true caring for patients and for colleagues. I am proud of Hopkins' more courageous efforts now to confront the crueler aspects of its origins and more recent institutional history. These were painfully evident in my time there. I am confident that Hopkins will emerge better, stronger, and even more inspiring for the next generation of physicians and scientists.
Dr. Theodore DeWeese is the Sidney Kimmel Professor of Radiation Oncology and Molecular Radiation Sciences, a Professor of Oncology and Urology, and the Vice Dean for Clinical Affairs at the Johns Hopkins School of Medicine. Most notably, he is the founding chair of the Department of Radiation Oncology and Molecular Radiation Sciences. By hiring outstanding faculty and staff, they were able to successfully build the department into one of the top radiation oncology departments in the United States. Beyond these faculty positions, he runs the Johns Hopkins Radiation Biology Laboratory, where his research included using a modified common cold virus to enter and kill only prostate cancer cells. Additionally, Dr. DeWeese is recognized internationally for his expertise in managing patients with prostate cancer. What distinguishes our dad as a great physician is his complete dedication to his patients. He sees his primary responsibility as a physician as being a guide for patients through their diagnosis and treatment of cancer physically, emotionally, and spiritually. He cares for his patients greatly. Many people don't know that he sees patients at their homes if needed, and he always gives them his home phone number. When working with a patient, he displays an expert level of care and empathy that he would wish for a member of his own family.
It goes without saying that Dr. DeWeese's dedication to his patients is only rivaled to that of his family. Despite his extremely busy schedule, our dad has always made time to come to all of our school and sporting events, even throughout college when we both attended schools in different states. He is always our first physician consultation for every fever, headache, bump, or bruise. After coming from home from work as a young resident at Hopkins, he would always give our mom a break from parenting by taking on the daunting task of lulling us to sleep. While a portrait cannot fully capture all of the amazing aspects of our dad, We are thankful the one aspect the portrait does not capture is the blinding glisten of light on the top of his bald head that we know no amount of makeup or Photoshop could have ever removed from a photograph. Congratulations, Dad, on a well-deserved award.
Good evening, everyone. First, I want to give a very special thank you to my son and daughter, Alex and Tiggs. I cannot tell you how much it means to me that you are presenting my portrait to the Johns Hopkins University. Along with my beautiful wife, Bonnie, the love and support all of you have given to me has allowed this evening and the honor of this portrait to happen. I love you all so much. I would like to extend my congratulations to my fellow honorees. I'm humbled to share this day with you. Thanks also to the Department of Radiation Oncology for helping make this day a reality for my family and me. The notion there would be a portrait of me in the Hopkins collection is nothing I ever predicted. And I am blessed to have so many great colleagues that have supported me over the years. Also, very special thank you to Alan Guerreri and to Herb and Phyllis Siegel for supporting the painting of this portrait. I am appreciative that Mr. Peter Egley agreed to paint my portrait. It was such a pleasure to work with Peter and Stu throughout the process. I owe a debt of gratitude to Paul Rothman and Ed Miller for believing in me and allowing me to serve Hopkins in so many ways, culminating in this day. Finally, despite what I am sure Tate and Alex mentioned, I believe Mr. Egley was proud to paint my bald head. I think the bigger challenge for him was whether he actually had enough white paint for my mustache. I thank you again for this great honor.
Hello, my name is Lance Chilton. As a previous recipient of this award, I am proud to introduce this year's community champions. The Johns Hopkins Alumni Association Community Champion Award recognizes outstanding contributions that address critical social, economic, and environmental needs throughout our society and communities, including local communities. The awardees may be either Johns Hopkins alumni who have impacted any community or non-alumni who have impacted a Johns Hopkins institution. Dr. Renee Blanding is the Vice President of Medical Affairs for Johns Hopkins Bayview Medical Center, and in 2013 launched the Readership to Leadership literacy program, in which she brings her lifelong love of reading to East Baltimore elementary schools. She works with teachers and community liaisons to offer programs such as Reading Bees, which provide students books to read during the winter and spring breaks. Dr. Laurel Toft is the director of the Cardiac Intensive Care Unit at the University of Louisville. Partnering with the Start the Heart Foundation, she designed a 5-minute CPR training method, Alive in 5, which has taught thousands of people CPR and increased awareness to learn for over 3 million. She also developed Heart Class to expand CPR training to high schools and resource-poor schools. Congratulations to both recipients of these awards, and thank you for all you do for your community and for Johns Hopkins.
There are so many benefits to giving back in the community, but for me, the work that we have with our reading programs in some of our elementary schools is the most rewarding, primarily because we see the appreciation and the encouragement from these students, from the teachers, and even our volunteers. And we also see a huge sense of pride in our students and accomplishment when they participate in our reading bees and our spelling bees and even our book fairs. And I can tell you that one of my most memorable occasions occurred at one of our book fairs, where I saw a little boy literally hug the books that he'd received. And he told me that this was the very first time that he was able to get books that were actually his very own. I was so encouraged by this because I recognized that we had an immediate impact in the life of this child, but ultimately our goal is to have immediate impact as well as long-term impact as we contribute to these children's literacy. And so I am so proud and so committed to creating the framework where we promote literacy, and I am so privileged to serve the public in this way.
The work that I do is a combination of biomedical research and community work. What we do is we teach CPR in high schools, and in particular pioneer new methods to train high schoolers that are better than the old methods. And what I love about this is that it has a direct impact on the community. So normally biomedical research can be separated from the people and the community that it's ultimately intended to serve. But in this work, we're directly there teaching people how to save lives through CPR. So even if I never publish a word of the research, we've still impacted lives by training people how to save lives. And for me, that's incredibly rewarding.
It is a great honor for me to say a few words this afternoon in tribute to Dr. Colleen G. Cook. Dr. Cook was appointed as the director of the Department of Anesthesiology and Critical Care Medicine and the Mark C. Rogers Professor of Anesthesiology in the Johns Hopkins School of Medicine in 2014. From the moment Dr. Cook arrived at Johns Hopkins, the department and the School of Medicine knew that she was a different kind of leader. Quite obviously, she was the first woman to lead the department. Colleen also made it clear that while she respected the legacy of Hopkins and Hopkins anesthesiology, she was here to forge her own path and intended to take the department to a new level. She immediately set to work to change the culture of the department because she recognized that such change could be transformational. She dedicated herself to educating and training senior departmental leaders in a program of serving leadership. The results of this effort were immediate and irrefutable. The ethos of serving leadership took root in every corner of the department and allowed us to create shared goals in which the primary question was always, as Colleen would say, what is best for our patients? And Colleen was one of the earliest advocates for improving the wellness of all members of the department. She didn't simply believe in the concept of joy in medicine. She personally brought joy to the department and Johns Hopkins. She modeled community outreach through United Way activities and with an amazing collaboration with the Community College of Baltimore to train the anesthesia technicians of tomorrow. Dr. Cook also transformed the department's missions of discovery and education. Her visionary leadership translated to the career development and success of faculty and trainees across all areas. And during her tenure, the impact of the department's publications increased, and the amount of extramural funding and number of funded clinician scientists more than doubled in the department. It was not truly a surprise to us when in November of last year, Dr. Cook announced that she would leave Johns Hopkins to become the Dean of the University of Florida College of Medicine. We understood that Colleen would have an even greater impact on improving the lives of patients and caregivers by stepping up to a higher position. Colleen, we thank you. You improved our department in Johns Hopkins through your vision and optimism. Your love for the department and its people was transformative, and our lives are better for knowing you. Today, we recognize you as a leader, colleague, and friend, and congratulate you on the presentation of your portrait.
I want to thank you for the opportunity to provide words of gratitude for my time at Johns Hopkins Medicine. I love my years as chair of anesthesiology and critical care. My department was filled with talented and committed caregivers, and for these members, I am most proud. It was a privilege to serve as their chair. I'd like to give a special thanks to my departmental leadership team over the years, Tammy, Aaron, Mira, and my project management office and staff. I am also grateful for the incredibly talented group of clinical directors who served as my colleagues. I'm grateful for Paul Rothman, who was a wonderful dean, my buddy Rob Kasdan, Kevin Sowers, the vice deans, and all the other faculty and staff I interfaced with as chair of medical board and as interim CMO of Johns Hopkins Healthcare. I hope everybody stays in touch. I consider myself lucky to be part of a wonderful community. Thank you.
Hello, my name is Dr. Shelby Wilkes. I have served on the Alumni Council since 2008. In addition, I have been a representative to the School of Medicine for the Alumni Council for the past 6 years. I am delighted to present the Johns Hopkins Alumni Association Heritage Award. The Heritage Award honors alumni and friends of Johns Hopkins who have contributed outstanding service over an extended period of time to the university or to the activities of the Alumni Association. This year, we will honor 2 outstanding alumni. Our first winner is Dr. Thomas Pearson. Dr. Thomas Pearson is an international leader in public health research and cardiovascular disease prevention. He's had a long-standing relationship with the university, which has encompassed 4 degrees, 2 residency, along with his investment of time and his resources. Dr. Pearson is a founding member of the World Heart Forum for Cardiovascular Disease Prevention, and he has been a major contributor to the American Heart Association prevention guidelines. In addition, he has a special interest in observing heart disease trends and the extent to which guidelines are carried out. Finally, he has lectured extensively and published on all of these topics. Our second winner is Dr. Linda Yao. Dr. Linda Yao served as her class of 1994 representative, and she worked tirelessly to organize her 25th reunion. Here are some of the activities she was able to accomplish. She arranged for all of the speakers, for the dinner, and she was involved in the composition of a 100 slideshow presentation commemorating her class of 1994. She personally contacted each member of her class to raise funds for the 1994 endowed scholarship for her class. Finally, Dr. Yao embodies all of the traits of an OSA Marine, which includes reliability, trustworthiness, honesty, and caring about Johns Hopkins and its graduates. Let us honor Dr. Yao.
I am deeply honored by the receipt of this, the Heritage Award, and my comments really entail what I think has been a privilege for me to have participated both in College of Medicine and College of Public Health, School of Public Health degree programs at Johns Hopkins. It has been a wonderful marriage of these 2 areas and has served me very well. Part of my joy of giving to Johns Hopkins had to do with then supporting the educational aspects of these 2 areas, which of course over the years have continued to come closer and closer together. This includes areas of preventive medicine, public health, clinical epidemiology, and the other things that I've done in my career, which really all started with the great teaching that I received on both sides of the campus at the Johns Hopkins Medical Institutions. And so it's this, it's some extent a breadth opportunity, but really more of a synergistic opportunity where I thought that my firm understanding of both these fields really provided opportunities for me to contribute to things that I thought were very important.
I have loved serving as the class representative for the fabulous Hopkins School of Medicine class of 1994. I really enjoyed working with the School of Medicine Alumni Office, which is really fabulous. It was great to reach out to all of my classmates, and especially to plan our 25th reunion in 2019, where we had 5 classmates give talks on their research as well as careers thus far. It was also great to see the cutting edge updates to medical education that Hopkins is known for. Because of the brainstorming at the 25th reunion dinner, I was able to chair the effort of the class of 1994 Scholarship, where we raised just over $100,000 in 18 months. It has been so rewarding to give back to our alma mater, where we started our medical careers. We are all looking forward to meeting the future scholarship students.
Dean Rothman, Alan, Vicki, and family and friends of the Brady. It is my distinct pleasure and an honor to be able to say a few words about Dr. Parton at the unveiling of his portrait. Alan started his career journey standing on the shoulders of giants, the leaders of the Brady before him. And now, as the fourth chairman in the 100-year history of the Brady, he stands with those giants. Alan started his career as the classic triple threat physician scientist. He did his PhD thesis describing the harmonics of cancer cell structure and function. I hate to tell you this, Alan, but what took you 3 years to do 30 years ago now is done automatically by a computer in 3 minutes. Be that as it may, the work you performed laid the groundwork for a generation of people studying cancer cell structure and motility, including myself. Basic scientist, check. As a resident and young faculty member, Alan changed the field of urology by identifying the prognostic factors associated with risk of recurrence for men undergoing radical prostatectomy. That work became known as the Parton Tables and has been the basis of how the entire urologic community guides treatment decisions for men diagnosed with prostate cancer. Clinician scientist, check. Several thousand prostatectomies later, Alan's skills as a clinician and surgeon are world-renowned. He has taught a generation of students and residents not only how to be a skilled surgeon, but also a compassionate physician. Educator, check. Alan did not stop at being the consummate academic triple threat. As director of the Brady, Alan enables and empowers us to be great. Hopkins continues to be the place where patients with complex urologic problems choose to come, students choose to train, and we as physicians and scientists choose to work and make a difference for humanity. Leader, check. Finally, let me just say that Alan is one of the most generous and fun people that I've had the pleasure to call not only colleague, but friend. Good human, check. Alan, on behalf of the entire Brady family, congratulations.
It is indeed a great honor to share this moment with all of you. To begin with, I'd like to thank Ken for his kind words, my wife Vicki, and family members who have joined me today for their years of support and, most importantly, tolerance. It gives me great personal joy to have served as the director of the Brady Urological Institute for the past 16 years. It has been an enlightening and inspiring experience to have played a part in the evolution of the Brady and Johns Hopkins medicine. Be it my role as a clinician, educator, researcher, mentor, or administrator, I have a profound sense of pride in the advancements we have brought to the field of urology. Finally, I want to give special thanks to my friends, colleagues, patients, mentors, and mentees. You have indelibly influenced my life and career. Thank you all for this opportunity and have a wonderful evening.
Hello, my name is Isaac Kinde. As the 2019 recipient of the Outstanding Recent Graduate Award, I'm honored to congratulate this year's recipients. The Outstanding Recent Graduate Award honors recent graduates of Johns Hopkins within 10 years of graduation for outstanding achievement or service in their professional or volunteer life. Dr. Carl Streed has advocated for the health and well-being of the LGBTQ community for over a decade and has been published in multiple top-tier research journals. His efforts are recognized locally by Johns Hopkins, nationally by the American Medical Association and the Obama administration, and globally by the World Professional Association for Transgender Health. Dr. Caitlin Sadler is currently the chief of the section of immunoengineering at the National Institutes of Health. She completed her PhD at the Johns Hopkins University, where she showed a critical role for T helper 2 T cells in biomaterial-mediated muscle regeneration. She was recognized as a 2018 TED Fellow and delivered a TED Talk that has been viewed more than 2.4 million times. Dr. Sadler was selected for the 2019 Forbes 30 Under 30 list in science and as a 2020 TED Med Research Scholar.
Actually, beyond the world-class education I got at Johns Hopkins, it's the network of mentors and collaborators and friends that have really contributed most significantly to my success as both a clinician in primary care as well as a researcher focused on LGBTQ health. The education has really laid the groundwork, but it is the network that has really allowed me to succeed both nationally and internationally on these topics.
This award really means so much to me. I was a student at Johns Hopkins for about 4 years, though it feels like much longer. In a good way though, because 5 years after defending my PhD, it still feels like yesterday. My mentors in my PhD program taught me the strength and importance of scientific research in medicine. Years of basic science resulted in a COVID vaccine going from viral sequence to distribution in under a year. An interdisciplinary effort of molecular biology, biophysics, and bioengineering. The CMM PhD program, my thesis advisor, Dr. Alicia, prepared me for the struggle of near constant small failures. Experiments not working, papers being rejected, a freezer losing power over the weekend. Knowing it's the long game for us, we build our successes over years, and sometimes have a really good day.
Hello, I'm Marie Nolan, Interim Dean of Johns Hopkins School of Nursing. It is my great pleasure to present to you today the portrait of Dr. Patricia Davidson, 4th Dean of the Johns Hopkins School of Nursing. As many of you know, Trish launched our school to new heights. She prioritized social justice and made sure that faculty, students, and staff all had opportunities to flourish. The portrait, painted by Peter Eggley, is a beautiful reflection of who Dean Davidson is. It is painted in warm tones. Oranges, yellows, and greens in the jacket dominate. Also, the background is painted in yellow and brown. It seems that her warm and welcoming personality affected the artist, as it did everyone. The high contrast between the bright colors and the black in the jacket suggests her vibrant personality. The subtle smile shows the confidence of a job well done. But maybe also a little mischief. There's humor behind that expression. She's leaning forward slightly, as if listening. Her 2 hands pointed in that direction suggest the same. Open to conversation, always focused on the person in front of her. It is how we will all remember her. The portrait will reside in our newly renovated School of Nursing building, accomplished through the leadership of Dean Davidson and generosity of our donors. Thank you all for your support and for the opportunity to share this special portrait with you today. Dean Davidson is an inspiration to us all, and her leadership and impact will forever be remembered and cherished by the School of Nursing community.
Today is a great honor for me in so many ways. Firstly, to have the honor of being the Dean of the Johns Hopkins School of Nursing for almost 8 years has been such a highlight of my career and truly an honor and a privilege. This portrait also has particular significance for me. My very first sitting was in the fall last year, just as we were all emerging weary from much of the pandemic. And I had the opportunity to travel to Southern Maryland. And as for someone who hadn't really not been out of East Baltimore for almost a year, it was such an extremely beautiful day. And Peter and Stu's house on the shores of Southern Maryland was like out of a picture book. And to have the opportunity to meet Peter and Stu was really something that was incredibly special. And I remember emailing to my friends in Australia saying, I just met the most amazing couple. And then to hear on the Monday that Stu had died was really so incredibly sad. I just felt so much for Peter. And at that time, my portrait was the very last thing in my mind. I just thought of the anguish and the grief of a couple just split apart in a nanosecond. And I just found it just upsetting and very emotional. Particularly because my area of research is sort of women and heart disease. I felt a real connection with them personally and with my story. And then to see my portrait finished just the way that Stu had envisaged it, with that jacket on, which by the way was just in what I wore for casually in the car down to Southern Maryland, with a box of very fancy executive clothes. And Stu looked at that top. She said, that's you. That's how we want to paint you. So in so many ways, this portrait is a story of many things. It's a story of my incredible privilege to be at the amazing Johns Hopkins. And I also think it's a story of a lifetime. It's a story of Peter and Stu's partnership. And what an honor. And I look forward in generations that my children will be going to Johns Hopkins and say, that was my grandma. So what an honor today. Thank you.
Hello, I'm Gretchen Burbeck, and I am proud to have completed both my residency and fellowship training in the Department of Neurology at Johns Hopkins. The Johns Hopkins Alumni Association Global Achievement Award honors alumni who exemplify the Hopkins tradition of excellence, bringing credit to the university and their profession in the international arena through academic achievement or humanitarian service. I am pleased to congratulate Dr. Karen Schneider as our 2021 honoree. Dr. Schneider is a pediatrician and assistant professor at Johns Hopkins, where she has been recognized for her international medical work in the service of children. She received an honorary doctorate of humane letters during the St. Joseph's College commencement exercises in 2019. She has completed more than 80 medical service trips abroad. Through her service in Haiti, Guyana, Nigeria, and Kenya, she has provided medical assistance to countless people in need, and equally importantly, has touched the lives of both the young and the not so young with her healing presence. Congratulations, Dr. Schneider.
I had some experiences as a medical student and pediatric resident in Guyana and Haiti. And these experiences woke me to the plight of the economically poor child in countries with limited resources. I couldn't shake those experiences. They were calling me to come back. And at the same time, I was looking for a fellowship in pediatric emergency medicine. I wanted to combine peds emergency with international work. And 22 years ago, every program I interviewed at told me that wasn't possible, until Johns Hopkins. The fellowship director said, "You'd be the first, but why not?" The Hopkins door opened to a pediatric emergency medicine fellowship, an MPH, and 20 years on the faculty. While obtaining my MPH, I sat next to people who were health ministers in various countries, and I listened. I learned what worked and what was futile. I learned how resource-plentiful countries and NGOs tried programs that failed. I learned to partner with the people in the countries, how to return multiple times, how to build sustaining relationships, and most importantly, I learned that they know what is best for their people. I've been able to create an international child health program where pediatric trainees, nurses, and faculty provide healthcare and surgical care to the children. And we've also provided equipment and in-country training for their healthcare providers. Most of our work is in remote areas. Approximately 4% of children are born with indirect inguinal hernias, which, if large, can interfere with the child's daily activities. We've created a program in Nigeria, Kenya, and Haiti, where children from very rural areas don't have to travel to the big city to get surgery. We bring the surgery to them. The world will not change if one child has surgery, but for that one child, the world will change forever. I am honored to receive this award. Thank you very much.
Dr. Robert Lair is a 1970 graduate of the School of Medicine and was the first Cuban American to do so. His family fled to the U.S. after the triumph of the Communist Revolution, and Dr. Lair has dedicated his career to giving back to the poorest and most marginalized in society, first locally, then around the world. He launched the first and only medical faculty exchange program between the U.S. and Cuba, which accounts for over 50 such trips.
On the occasion of receiving the Samuel Asper Award, I want to thank, first of all, my parents, who, as refugees from Castro's communist Cuba in 1960, sacrificed so much so that I could attend both college and medical school. Secondly, I want to thank my classmates from the class of 1970. I learned a lot from you. We shared a lot of trials and a lot of laughs, and we still keep up with one another. Finally, I thank my Hopkins professors. During the preclinical years, Drs. Leninger, Mountcastle, Nathans, and Talalay in particular. And most influential during my clinical years were Drs. Cook, Dr. Harvey, Dr. Tumulty, Dr. Momini, and Dr. Samuel Asper, who was one of my instructors in physical diagnosis year 2. Thank you all.
Good afternoon. I am Dr. Ann Murphy, and I am the president of the Johns Hopkins Women's Medical Alumni Association. This afternoon, it is my honor to present the first of 2 nominees for this award, and her name is Dr. Estelle Gauda. She had a long history of being a faculty member at Johns Hopkins before she became the chief of neonatology at Toronto Sick Kids. And she's recognized as a teacher, mentor, and scholar.
I want to take this opportunity and thank each one of the individuals from the Alumni Association for selecting me for this award. It is a true honor, for sure. It is especially important to me to be recognized for the mentoring that I've done for young students, medical students, and others, particularly those of color, and my position at Johns Hopkins allowed me to do that. I also want to say that I was around amazing people who gave me amazing opportunities to be who I am today. And I want to make a special thanks to Dr. Janice Clemens for believing in me and my leadership skills and giving me the opportunity to lead at Johns Hopkins. Thank you.
My name is Rachel Levine, and I am the current Associate Vice Chair for Women in the Department of Medicine. It is my great privilege to provide this introduction of Dr. Susan McDonald, who today is bestowed the honor of being inducted into the Johns Hopkins Women's Alumni Association Hall of Fame. Dr. Susan McDonald was a true pioneer, always fearlessly advocating for women. Dr. McDonald graduated from Regis College, earned her MD from the University of Massachusetts, and came to the Osler Internal Medicine Residency program in 1980, where she served as an assistant chief of service. She then completed fellowships in both rheumatology and clinical immunology. Dr. McDonald developed an early interest in the promotion of careers of women, initiating a mentoring program for women fellows. She chaired the Department of Medicine's Task Force on Women's Academic Careers in Medicine from 1995 to 1997. In 1997, she became the Deputy Director for Faculty and Career Development in the Department of Medicine. Recognition of her innovative and impactful work in that role led her to the School of Medicine Office of Faculty Development in 2001, where she led the work on developing the Professional Development Guide for Faculty, now known as the Silver Book. Dr. McDonald was the first woman associate chair of the Department of Medicine. She received a Women in Leadership Award from Johns Hopkins University in 2002, the David M. Levine Excellence in Mentoring Award in 2003, and became advisor to the Office of Women in Science in 2008. She served on the Advisory Committee on Mentoring for Johns Hopkins University and received the inaugural Vice Dean's Award for the Advancement of Women in 2009. She was interim director of the Division of Allergy and Clinical Immunology until her retirement in 2016. Dr. McDonald was an accomplished scientist. Her laboratory focused on mechanisms of histamine release and developed the first inducible transgenic mouse model in this field. Dr. McDonald was a member of a number of allergy and immunology societies. She served on the editorial board for the Journal of Allergy and Clinical Immunology and multiple advisory committees and review groups nationally and internationally. As Professor Emerita, she continued to mentor and wrote grants for community foundations. I am so proud and honored to bestow this induction on Dr. McDonald today.
I'm so incredibly pleased to accept this award on behalf of my wife, Susan, who peacefully passed away at the Johns Hopkins Hospital in September 2020 after a lengthy illness with her sister Karen and myself at her bedside. We spent over 20 years being happily married, and for those who knew her, I'm sure she would tell you how much she would appreciate this award. So thank you so very much.
I want to once again congratulate each of our award and portrait honorees. Thank you for your dedication and perseverance over the years, especially over the past 13 months. I would like to thank all of you, families, friends, and colleagues, for joining us today.